Okay, so everybody, I'm Dr. Kelly Teagle. We're about to start our broadcast. I'm joined today by Marita O'Shea, who's my friend and pelvic floor physiotherapist. Marita from such hits as our Sexual Problems at Menopause webinar only a couple of weeks ago. So, hi Marita.
Hi, Kelly.
So we'll just give everyone a couple more seconds to arrive, and then we'll get started right on 7 o'clock. We've got quite a few registered now, so yeah, it'd be lovely to see a few people actually here live. For those of you that are here now, don't forget that you can add questions through the chat function on the way along, and we'll get to those questions at the end. All right, so it's just on 7 o'clock now, so let's get started. Hi everyone, I'm Dr. Kelly Teagle from WellFemme Women's Health Services, the Telehealth Menopause Service, and we're here today to talk about bladder problems at menopause. I'm joined today by my good friend and pelvic floor physiotherapist, Marita O'Shea, who works here in Canberra as well, and she has joined me on webinars before. You might be able to remember seeing Marita at the Sexual Problems at Menopause webinar. So thanks for joining us again, Marita.
Fine, Kelly.
Okay, so thanks for joining us, everybody. As always, the information that we provide today is literally just for informational purposes. So if you need individual medical advice, make sure you go and talk to your own doctor to see what suits your particular situation. So this is our overview for today. I'm going to be presenting about what urinary issues can occur at menopause, how common they are, what causes them, and what can be done about them. And then Marita is going to take over, and she's going to go into quite some depth about actually the practical aspects of how to manage urinary urgency, particularly, and some other urinary problems at menopause. Right, to get started then, the types of urinary issues are very straightforward really. There's urgency problems, there's stress problems, and there's a mixture of the two. So urgency problems is when you feel the overwhelming urge to urinate, and it's kind of like when you're coming home from work, you put the key in the door and you all of a sudden get this busting urge to go, and you feel like you're going to wet yourself before you can get inside and go to the toilet. Incontinence. So it's that sense of urgency that you need to go right away. Then there's stress incontinence as well, and this is where you get involuntary leakage of urine because there is a problem with the sphincter of the urethra, which is the little tube that lets the wee come out from the bladder above the vagina there. And if that sphincter isn't functioning properly, then anything that causes increased stress, like coughing, sneezing, laughing, jumping on a trampoline, that can cause urine to leak out. So those are the two main types of urinary issues, urinary incontinence related issues. And then some people are a bit more complicated because they can have a mixture of the two different types. Now, one of the things that's very, very common at menopause is the overactive bladder syndrome. And what I mean by that is that you get that urgent feeling, the urgency to go to the toilet. And it's usually accompanied by needing to go fairly often and sometimes needing to go during the night as well. So you're having to get up during the night. And that's with or without incontinence where you actually leak. It isn't explained by other medical factors or pathological factors. So it's just that sense of urgency and the fact that the bladder, which is one great big muscle, is overactive. It wants to contract at inappropriate times. How common are these urinary issues around menopause? Well, just like the last one that we talked about, the mental health issues, the answer is very common. From the Continence Foundation, I picked up some statistics here that urinary incontinence affects up to 13% of Australian men and up to 37% of women. So you can see it's about 3 times more common in women. And about 50% of women around about menopausal age had some degree of urinary incontinence over a 3-month period. So that's only over a 3-month period. That's not even during their life. Also, 70% of people who have urinary leakage don't seek advice or treatment, which is a bit sad because as you'll see when Marita starts talking to you shortly, there are actually some really good effective treatments that can be easily done. So why do we get urinary issues around menopause? Well, it's kind of a combination of things. You may be aware of the fact that at menopause we're getting not only a decline in our estrogen, but also fluctuations up and down, some variation in the different reproductive hormones. So that has an impact on the bladder because, like all the other tissues in the body, there are hormone receptors on the bladder. Also, there are physical factors which are caused by just your lifestyle, things that have happened to you during your life. So, for example, you're going to be developing a weak pelvic floor just through general aging and through estrogen deficiency and various other things. The bladder becomes stiffer as we get older. It's less elastic, which means that it doesn't give as much to accommodate so much urine in it, and it wants to contract, it wants to let wee out when it feels too full. There's vaginal and urethral dryness and tissue thinning associated with the loss of estrogen at menopause. There's weight gain, which causes an increase in stress on the bladder and makes it very difficult to hold your urine. Then there's all sorts of other medical and health problems that can contribute, such as diabetes, for example, which affects the nerves to the bladder. There's things that cause coughing, which could increase stress on the bladder. Fibroids on the uterus can be pressing on the bladder. Endometriosis can be irritating the bladder as well. There's various medications people might be on, and those are just a few examples. So there's lots of that stuff. And things that cause pelvic trauma, such as childbirth or surgeries where you've had a hysterectomy or prolapse repair, those sorts of things are interfering with the structures of the area that normally support the bladder and make it work properly. Now, there's a bunch of treatments for urinary issues around menopause. The first line stuff is the stuff that I'm going to leave Marita to talk to you a bit more about. This is the easiest stuff that you can do when you've got a problem, things to do with lifestyle, for example, changing your diet, making sure that your bowels are working properly, and then some training techniques that Marita's an expert at and she can coach people in. Then there's a bunch of medical and surgical options to treat overactive bladder as well. So a whole raft of different medications that you can see there, some examples. And I'd really be interested to know just exactly, how many people have had some of these medications. Now, I'm not actually sure how to put that poll up, so I'm not going to bother about that. But I'd like to know how many people have actually been on medications and whether they thought they were effective. So if you're watching now and you've had an experience with medications you want to share, please put it up in the chat function. There's also lots of potential side effects from those medications, though, that we don't like sometimes, like constipation and dry mouth. So they have to be selected to suit the person, and we have to monitor for the side effects. Estrogen is often used, so transvaginal estrogen is really commonly used if you've got vaginal dryness and urinary frequency or urgency as well. You might find dual benefit in using some vaginal estrogens because that plumps up the tissues and supports the urethra much better. If some of these other medical options don't work, the gynecologist or urologist might be able to inject some Botox into the bladder, which can help to stop it from being so irritable and contract inappropriately. Then there are more advanced types of procedures like sacral nerve stimulation and an operation called bladder augmentation, which is just designed to actually make the bladder a bigger volume. But those are the more extreme kind of things there. Oh, and I missed an R off the end of bladder. Sorry about that. Okay, Pip has just shared with us that she's used Betmiga and she found it good but very expensive. And yeah, that's been the experience of a lot of my patients as well. So I sympathise, Pip. Shelley's use Ovestin cream. That's one of the vaginal estrogens that does help to plump up the tissues around the vagina and urethra. And yeah, that's a really effective approach for people who clearly have got some vaginal dryness and atrophy. Now I'm going to hand over to Marita. I need to get rid of
Okay.
my slides and Marita can put up her slides.
Okay. We're right? Yes. Okay, so as Kelly said, I'm a pelvic floor physiotherapist, and a lot of what I do in my day-to-day treatment with patients is talk to them about bladder issues. And a lot of women will come in around menopause with those things that Kelly talked about, urgency or stress incontinence. And sometimes it's a new onset, they've never had issues at all before, and menopause seems to be the trigger. Other times, a lot of women I see have had some problems, say, around childbirth, and have managed to get on top of them and have managed quite well for 10 years or so, and then they come and become a problem again around menopause and perimenopause. So the common things that we tend to see, and this is again what Kelly said, so stress incontinence, where we're leaking urine with exercise, laughing, coughing, sneezing, bending over, lifting up something, and it's to do with the pressure on the bladder. Women may need to get to the toilet in a hurry and often not make it in time, and they can be triggered by things such as what we call key in the door urgency or running water, those environmental triggers and habits that tend to make us want to go to the toilet, or frequently needing to go to the toilet or getting up more than once or twice overnight. And when we've got other symptoms of menopause, so like not sleeping very well or hot flushes and things like that that happen at night, sometimes it's really tricky to work out what's actually waking us. Is it our bladder or is it actually something else? And then because we're awake and we can't go to sleep, we then tend to get up to go to the bathroom. If a patient who I see says that they have difficulty emptying their bladder, or they have to move around on the toilet seat, or they might stand up and then leak after they think they've finished, that can often indicate that they've actually got a cystocele or an anterior vaginal wall prolapse. So as Kelly mentioned, with menopause, we get that drop in estrogen, and that affects the urethra and the bladder and the pelvic floor muscles. So what happens at the urethra is that we just lose some of those muscle fibers, and we get reduction in the blood flow and reduced elasticity of the tissues. So at the level of the urethra, what tends to happen is we just don't close the urethra off as well as what we used to. And probably the easiest way to understand this, it's a little bit like a washer in a tap. It's worn a little bit, and even though we're trying to close it off, we still get a little bit of urine dribbling out. With the bladder itself, the bladder is actually a muscle, and what happens in menopause is we get some thinning of the lining of the bladder mucosa, which is just the inner part of that muscle. And this actually reduces the threshold of bladder contraction. So what happens then is we get that sense of urgency often when we actually don't have a full bladder. So we can get it with very small volumes of urine. We also get changes to the pelvic floor muscles. Just with aging, we'll get a reduction in muscle mass. There's less collagen within the tissues, and again, we get reduction in strength and elasticity. So just the pelvic floor muscles don't work as well as what they used to. So the main incontinence problem that I see at menopause would be urgency and urge incontinence. And I think when we're trying to understand the difference between this and stress incontinence, it's really important that we think that urgency is more to do with our bladder and the bladder contractions rather than our pelvic floor muscles. Our pelvic floor muscles are involved with controlling urge incontinence, but the trigger for urgency is our bladder. And it's kind of our bladder and our brain. And they're the two things that we're trying to focus on in the treatments of urge incontinence, which I'll go through in a minute. So you can see here with this slide, our bladder's filling up, and all of a sudden we'll get this sense that we need to go to the bathroom. And it's obvious by that picture there that we're rushing and we're not making it to the toilet. And it is quite common. As I said, and this type of urgency, this type of incontinence actually gets a lot worse as we age, especially as we age and get into our 60s and 70s and 80s. So it's really important that you've got any symptoms of urgency and urge incontinence around menopause, that you try and get it managed, because we know that over time that it won't get better on its own, and it often does get worse. So, as I mentioned, when we're trying to manage urge incontinence, we're really looking at the connections of the bladder and the brain and how we respond to that sense of urge that we get. So we're trying to retrain the bladder, and when we get a bladder spasm, so when the bladder starts to contract, what we're trying to do, instead of rushing to the toilet, like you can see in the picture above, is that we're trying to stop the bladder urgency and let the bladder actually calm down. And when it's calm, that's when we try and make our way to the toilet. So we don't want to rush. We're actually wanting to get to the toilet slower and in a calmer manner rather than rushing. So we talk about urge suppression strategies. So if we get urgency, so let's take the example of coming home, getting out of the car, trying to find your keys and open the door. So as soon as you start to feel that sense of urgency, we actually want you to stop still. So you're standing still, you're not trying to get your keys out and make your way into the house. You actually stop. The next thing that can be really helpful is actually putting some pressure up around your perineum, the vaginal area and the urethra. So a nice firm pressure up there, but you're not going to put that pressure on and run to the toilet. You're going to put the pressure on around the urethra and actually still be in a standing position. The other thing that's really helpful, and it's to do with what we call neural inhibition, is that we get you to raise up and down on your toes or curl your toes. So you're actually doing this while your hand is up around your perineum. You're then raising up and down on your toes. And why we do this is that it's to do with the nerve roots, and the nerves that supply the muscles around the calf also have an innervation to the bladder. And if we turn one on, it tends to inhibit the other one. Then we start doing some mindfulness type of activities where we try and slow ourselves down. And positive talk is really good. Saying to yourself that you can do this, and getting a little bit cross with your bladder, especially when you know it's a trigger like coming home or turning a tap on. It's often useful too to distract yourself. And some people will count backwards or just do something that takes a little bit of effort, so they're taking their mind off their bladder. We go through some relaxation techniques with breathing, and the main aim with this is not to walk while your bladder is trying to contract. So we're trying to calm it down, and then we might open the door. What tends to happen with urgency though, it tends to come back. So if you've had urgency, you'll know that when you get it, it gets a lot worse the closer you get to the bathroom. So you might be able to manage it as you're coming in from the garage and got the door shut, but then as you walk towards the bathroom, this urgency comes back again. So if that's the case, you're actually going to repeat all these strategies again with the aim of walking into the toilet in a calm manner. And what you don't want to be doing is undoing your buttons or your zip or pulling down your knickers before you're actually at the toilet, because that really triggers your bladder to go. So if you're touching your underwear or your trousers, what that tells your bladder is empty, and it will. So you really can't be doing that until you're actually at the toilet. The other thing with bladder overactivity, if we're talking about it as an overactive bladder or an irritable bladder, what we drink has a really big impact on our bladder contractions. So we want to try and reduce the bladder irritants. So they're things such as caffeine, artificial sweeteners that you may put in your tea and your coffee. Alcohol is also a bladder irritant, and carbonated drinks, so those fizzy drinks. So we're trying to reduce bladder irritants, not eliminate them, but it's trying to work out what our triggers are and trying to reduce the things that make our bladder worse. And also smoking is a bladder irritant. So good bladder habits, what we should be doing is trying to have about 1.5 to 2 litres of fluid per day. That does not have to be all water, but if you're having caffeine and things that can irritate your bladder, you want to make sure that the things that don't irritate your bladder, like herbal teas and water makes up the majority of what you're drinking on a day-to-day basis. We want to get out of the habit of emptying our bladder just because we can. So when we're leaving the house, or when we're coming home, or just because we've passed the toilet, or just because your friend's going, doesn't mean that you need to go with them. And women are fairly notorious for going to the toilet in groups. We should sit properly on the toilet. We don't want to hover over the toilet seat. This is really important if you have a prolapse. We do need to make sure that we're sitting and emptying correctly, so that we know that when we get up, our bladder is empty, which should stop us thinking we need to go back again within 10 minutes or so. And we shouldn't need to strain to empty our bladder. If that's the case, again, it might indicate that your pelvic floor might be a bit what we call overactive, or you may have a prolapse. So we know a healthy bladder can hold around 300 to 400 mils during the day, so our day voids, and at night it would hold a little bit more. So if we're sleeping through the night, not getting up, we might have 500 or 600 mils in our bladder for our first void of the day. If we drink 1.5 to 2 litres of fluid per day, it would be normal to pass urine 5 to 6 times. So we'd get up in the morning and we'd have a wee, we'd have one before we went to bed, and then 3 or 4 times during the day. Our frequency is very dependent on our fluid volume as well. So if we drink a lot more, we may go to the bathroom more frequently. But what's really important, and what I do with my patients, is that I'll actually get them to do a bladder diary, and we're actually getting people to measure their volumes, because if you have a large bladder, a large fluid volume, you may go frequently, but your volumes should still be fairly a reasonable amount. So it's when we have frequency with really small volumes, and we do see women coming in voiding 50 mils or 100 mils, that's when we really need to start implementing these bladder retraining strategies. So it is difficult to say exactly what your voiding should be without doing a complete bladder diary, and that's why we do it. Stress incontinence, as we mentioned, is due to a physical stress on the bladder, so an abdominal pressure increase, which happens with coughing and sneezing and laughing and jumping. And the reason why women get stress incontinence often is because they have a weak pelvic floor. It might just be a pelvic floor that's getting weak as we get older and haven't done any strengthening, or it could be that these pelvic floor muscles were damaged during childbirth. And what can happen then with deliveries, sometimes we'll get a loss of support of what we call the bladder neck, or bladder neck hypermobility, and that's a reason why women can get stress incontinence even if they do actually have a reasonable pelvic floor contraction. With an assessment that I would do, which is a vaginal assessment, you can actually determine the reason why someone's getting stress incontinence. Again, we do see a prevalence of stress incontinence around our mid-40s and upwards. So basically, the management of stress incontinence, because the mechanism is very different to urgency, the most important thing is to look at our pelvic floor strength and do a really good pelvic floor strengthening program. And we also talk about functional pelvic floor activation. So if you're leaking urine on your when you're running, or if you're at the gym, or even with coughing and sneezing, we do tend to leak more when we're standing up. And I get a lot of women that say they're doing their pelvic floor exercises, but they just do them either sitting or lying down. So you need to choose a functional position for them, which for stress incontinence is usually in a standing position. The other thing with stress incontinence, we know that if we're overweight and not our ideal weight, it puts a lot more load on our bladder. So trying to lose weight, if that's what we need to do, can actually have a really positive effect on managing stress incontinence. If someone has stress incontinence with exercise, we can choose to offer a support device, which we call a pessary. There's also one that is called a contiform, and a physiotherapist or gynecologist can fit those. A simple thing to try if you're, say, a runner and you're leaking, is to put a super tampon in for your run. And if that actually improves your incontinence and you're not leaking, it would probably indicate that you do have a bladder neck mobility issue. And it is something that some women will use just to be a little bit drier with their running. If this doesn't improve the situation, some people are okay to change their activity. So if they're running, they may choose that they don't want to run anymore and they might use a cross trainer or ride a bike. But for some women, that's not acceptable. And, changing our exercise routine, we might need to be doing some impact exercise for our bones, especially around menopause. So we do have to look at balancing and doing the right type of exercise. And there is surgery that can be done for stress incontinence, and that's what we call a suburethral tape. It's a bit of tape that the gynecologist puts under the urethra, and it supports the bladder neck. And for some women, the outcome is very successful. So that's a quick summary of bladder issues at menopause. So thanks, Kelly.
Yeah, that was excellent. Thanks very much, Marita. You've covered off on so much information there as we were going along, and you're just talking about, the things you have to do when you're standing outside your house with the key in the door. And I'm just getting an image in my head. I was getting an image in my head there of some poor woman in her driveway with the neighbours kind of looking over, and she's sort of standing there holding onto herself and trying to stop the urge before she calmly opens the door and goes inside.
Yes.
But it's
a common scenario.
Exactly. Mm-hmm. And a few of the ladies have been commenting. They've been doing that, like Jenny mentions that she's doing the bladder talk and it actually seems to work, and Michelle said that she's already been trying some of those similar things as well. So that's really good information.
Yeah, a lot of women do. They say that they're already trying.
Yeah, exactly. I was interested when you got to the end there and you were mentioning about surgeries. I've had patients that have come back from their gynecologist, and the gynecologist has mentioned an injection of a filler around the urethra. Have you heard of that procedure, and how successful do you think that is in people?
Yeah, that can be for certain issues with incontinence. That tends to improve the internal urethral sphincter. So it's really to do with improving the closure pressure of the urethra. So not really for stress incontinence. Some women, especially as we get older, can leak for no reason. So we've mainly talked about urgency, which you get it's urgency. You get that sense of urgency and you're actually leaking on the way to the toilet. And then there's the stress incontinence. There are a group of women that leak and there's no provocation. They just say to me, I'm just damp. I don't feel it. It's all of a sudden my undies are wet before I've noticed. And they can often have a intrinsic sphincter deficiency. And I think that's when that type of treatment would work. We've lost you. I can't hear you, Kelly.
I muted myself and then I forgot to unmute.
All right.
So I've had a lot of ladies come back after that and find that it hasn't been fully successful and they've had to go on to surgery, but it is something that they can try, short of actually having to go down the path of the actual surgery. So a lot of people do like to try it. So let's see if anyone in the audience has any questions. I'd love to. Somebody's saying they can't see me. Okay, can you see me all right, Marita?
Yep.
Oh, okay. I'm sorry if you guys can't see me. I hope you can hear me at least. But if anyone's got any questions for Marita, particularly about bladder issues, about anything to do with medications, you can ask me. Oh, thank you, girls. You're all telling me you can hear me. Well, that's good news. But now's your chance to ask Marita any questions that you might have about bladder training, specific, stories that you've got about what's worked for you or what hasn't worked. We'd love to hear about that. I'd like to know, Marita, what do you feel like your success rates are like with the bladder training, particularly with ladies, who come in with the urge incontinence?
I think urgency, especially in a a younger group, so our menopausal group, as opposed to our 80-year-olds, it can be very successful. So with bladder retraining, I will often get women coming in after their review. So usually I'll give them about 4 to 6 weeks. And most of them will say they've made really good improvements. And that's not with medication. It's not even really with pelvic floor strengthening, because you don't get strength gains in 4 to 6 weeks. That's at least a 3-month period. So you can get some early positive changes with urgency, especially when women are able to change their fluid intake and reduce their cups of coffee and cups of tea. Stress incontinence takes a lot longer, because what we're really trying to do with stress incontinence is improve the integrity of our pelvic floor muscles. And if we're trying to lose a little bit of weight, that is more of a long-term issue. So a lot of women really can take that good 12 months to feel like they're getting on top of their stress incontinence, whereas urgency, you do see positive effects a lot earlier on, which is good.
Yeah, excellent. Yeah, that's the great thing about the urgency, at least, that we know that there's loads of things that we can do just in general practice that are short of having to have surgery that can make an enormous difference. Okay, so I've
Yeah.
got a couple of comments here from patients. Anne says that sometimes she gets lower groin pain if she doesn't go as soon as she gets the urge. What do you say about that?
There's probably no direct connection to the groin muscles. Why? Unless it's probably just an overactivity, like an anxiousness, just using and recruiting any muscle that you possibly can to hold on, especially if your pelvic floor is weak. So even with that, we would still be doing the calming techniques. And you do hear women saying they get tummy pain, and I think it's just that anxiousness, the fear that they're going to leak, and just trying to it's a tension thing. There wouldn't be any other reason, I don't think.
Yeah, I would be interested to know with that too. If she was my patient, I'd be asking about other things, that might be affecting the pelvis, like endometriosis and things like that, that could be impacting there when the bladder's overstretched or something. Okay, a couple of other ones here. We've got Shelley's mentioned that she's found HRT's been helpful for the bladder. She doesn't get up at night anymore, and previously she was up a couple of times each night. So she's been doing pelvic floor exercises as well for 2.5 months. So this is a lady who has she's found some benefit from the combination of doing HRT and pelvic floor exercises. So that's great. So Trish says that her gyno has recommended that she sees a pelvic floor physio. She suffers from urgency, and if she's busting, she can leak a little bit. And she's had a hysterectomy 10 weeks ago as well. So that's a whole different kettle of fish, isn't it, Marita, when you've recently had surgery as well and everything's stirred up down there?
Yeah, that's right. You'd want to know whether she had urgency prior to the hysterectomy or whether the hysterectomy was the trigger.
Yeah, whether that's just stirred some things up there for sure. Okay, Maria says she has urge issues but doesn't have to get up during the night, and the GP's given her a script for vaginal estrogens. Will this help? Yeah, that's a good question, Maria. The vaginal estrogens may help, certainly. I don't usually prescribe them for people just for urinary urgency unless they actually have got some evidence of vaginal dryness or thinning of the tissues there as well, because then that's an indicator that there's generally some dryness and thinning and what we call atrophy of the genitourinary tissue. So if that's the case, then you may well see some improvement from vaginal estrogens, I would think.
Yeah, certainly
okay,
I was just going to comment that in the women that I see a lot of women on vaginal estrogen, even without dryness, and it can actually really help, especially if they get a urethral urge. So when you get urgency, a lot of women around menopause will say they get a urethral urge, so it's right down low, rather than someone else that just has a full bladder. And if your bladder's full, you tend to feel it in that lower abdominal area. But when you're getting that urethral urge, I think the local estrogen is actually quite helpful.
Okay, so what you're saying is that if they actually feel it sort of lower down rather than just a general urge to go, so I mean, do you mean that they get this kind of sort of a stabbing sort of feeling down in the urethra when they need to go or something like that?
No, it's just that's where their sensation is. They just feel it's
Yeah.
almost they're about to leak, and it's more an irritation rather than, their tummy and their bladder feeling very
Okay, yeah,
full.
that's really interesting. So,
Mm.
I guess it kind of makes sense that if we're estrogenizing that area through using vaginal estrogens, and there's estrogen receptors in the bladder as well, that, it's going to be having some impact on that whole area, regardless of whether there's much vaginal dryness then.
I think
Yeah.
so.
Okay. So let me see where we're up to here. Michelle says she's seen a pelvic floor physio for bowel urgency who recently advised that women in general should be doing pelvic floor exercises daily. Michelle has damage of the wall between the bladder and the bowel. Are regular pelvic floor exercises absolutely necessary daily for good bladder control for the rest of our lives, Marita?
In a word, yes. The
Hmm.
pelvic floor muscles are like any muscle in our body, and as we age, they get weaker. So it is important to have a good routine, and a daily routine is great. And if there has been any damage to the pelvic floor, which is what was mentioned in this question, then you do need to try and be as strong as you can to try and support that weakness that you may have. So, yeah, there's lots of reasons to be doing pelvic floor exercises on a daily basis.
Yeah, absolutely. When I was trying to work out a way to get pelvic floor exercise into my day, I decided that I was going to do it every time I washed my hands, because as a doctor, I wash my hands a great number of times every day. And so what I do is while I'm washing my hands, I'm holding a pelvic floor contraction at the same time as I'm washing my hands. So any of you who see me actually in my rooms, don't look at me weirdly when I wash my hands, but that's exactly what's going on.
Yeah. And I think if you're
Mhm.
trying to do them on a daily basis, it's good to have some kind of trigger. And I'll often say to women things like teeth cleaning. You do that twice a day. You do it standing up,
Mm,
and it's a good functional position, or in the shower. Those types of things. So you do
mm.
need a little trigger to remind you, because yes, they're a bit boring, and most of us forget. But it's important to have some routine, I think.
Yeah, yeah. So if you just build it into some of those daily activities that you do frequently, it's going to be much easier to remember to get them in there, isn't it?
Yeah,
Mm.
exactly.
Now, Lyndall has asked about something that I am not aware of, but you may be, Marita. What do you think of M-Cellar treatment? Do you know about M-Cellar?
No.
Mm. Lyndall, if you're
I
watching, Lyndall, why don't you give us a little bit more information about what M-Cellar is? I'm afraid I haven't heard of that one. Um, right now, Denise, is brisk walking beneficial? Hmm. Well,
Well,
what
it's
do you think about
beneficial
that,
for
Marita?
lots. Well, it's beneficial for lots of reasons, for just general health, for
Exactly.
fitness. It probably doesn't have a direct link to bladder urgency, but it's a good general exercise to do.
Hmm.
So yes, it is.
Yeah, yeah, I would have to agree with that, unless you're very briskly walking towards the toilet because you're feeling like you have to go in a heck of a
Yeah.
hurry. Okay, so Michelle says that now she's going to try and remember to do pelvic floors when she's driving. Um, Jeanette, I like the routine of washing your hands. How many times should you do each time? Okay, what do you think is a good rule of thumb, Marita, when you're doing pelvic floors? Should they be doing short contractions, or should they be holding a sustained contraction? What's the story there?
Yeah. Well, there's lots of different types of contractions you can do. I suppose sometimes it's difficult to give a recipe, because it does depend on how strong somebody is. But if we're looking at strength training, we're trying to do 10 to 12 repetitions consecutively, holding anywhere from like 1 second if you're really weak, up to around that 6 to 8 second mark, and trying to hold these contractions as strong as possible. If
Mm-hmm.
someone's a little bit more advanced than that, they can do that, and they can also add in some endurance holds, where we might say you're going to be holding for that 10 or 12 seconds onwards and doing a couple of repetitions of those. Some people also do quick flicks where they just kind of turning the pelvic floor muscle goes up and down, up and down, up and down. And that can be useful as well. So there are combinations, but I think if you're starting out, I would be doing the strong contractions for those 1 to 2 seconds, 10 to 12 repetitions, and then progress from there.
Okay. And, I don't know what your tip is when you're talking to people about how to know whether or not they're actually correctly activating their pelvic floor. But one of the things that I do in general practice, of course, and I know you do too, Marita, is that we're doing a bimanual examination on the patient where we actually put our fingers in the vagina and at the same time as that's going on, do a pelvic floor contraction so that we can feel the strength of that contraction. One can actually do at home themselves, isn't it? That they could test themselves if they can feel the pressure on their fingers, or they can starting a flow of urine or something like that. Yeah.
Yeah. Just to get a bit of feedback.
Okay. Exactly. And there are, of course, devices and things that pelvic floor physiotherapists recommend, like some weights that women can squeeze on and hold, or some, pressure sensors that can tell them immediately with feedback exactly how strong the contraction is. Okay. So that's about it so far for the questions. Is there anything else, Marita, that's come up for you that you think that you'd like to tell us about with regard to urinary urgency or overactive bladder or anything like that?
Look, I think just with urinary urgency, I think there are some women that come in to see me, and the first thing that their GP has done is put them straight onto the bladder calming medication, so the anticholinergics. And I think really the first thing to do is to look at someone's fluid intake and to try and do those behavioural management strategies first. And then I think medication is appropriate if those conservative measures fail. And I think you mentioned in your first part of the talk, Kelly, that those medications, because they affect the smooth muscle, they actually are non-selective, and people do get things such as a dry mouth and dry eye. So they're actually really not that well tolerated. And after about 3 months, most people decide that that's not for them. So I think the best step is to do the conservative management first, and then move on to medication. If you have a picture of incontinence that's a little bit mixed, so you may have some stress incontinence, you may have urgency, there might be that unprovoked leaking, getting a really good diagnosis by seeing a urogynecologist and having a urodynamic study for those really more complex cases would be appropriate, especially before you were offered surgery for stress incontinence, to actually work out what's happening.
Yeah. No, I agree. When there's a bit of a mixed picture, I'm often sending people off to the gynecologist to have those special urodynamic studies done. And when it comes to the medications, those side effects can be quite significant for a lot of people. And in fact, it can make some of those medications inappropriate for certain patients, like particularly elderly patients, because it can make them sedated or more prone to falls and things like that as well. So, we do have to be quite cautious in our approach to medications, of course. So I think we'll wrap it up there. Thanks everybody for watching. I just wanted to mention, you may have seen a special offer pop up at about the 35-minute mark. October is World Menopause Month, and to celebrate World Menopause Month, here at WellFemme, we're trying to get the conversation going around menopause in positive, empowering ways. So we're starting a campaign called Tell Your Menopause Story. There's a Facebook page, and at the moment, nobody's stories are on there. It's all a fresh, clean slate. So as the first people to be told about this, I'm hoping that some of you will be able to hop onto the website, and I'd love to hear your empowering personal positive stories about menopause, special tips that you have, things that you've learned through menopause, things that you could tell other women to help inspire them and make them feel more optimistic about menopause and life beyond menopause. So get on board with that. The first 20 people who post their stories, I'm going to be looking at those very carefully and choosing the most positive special story on there to be gifted a free comprehensive menopause consultation with me. So yeah, I'd love to hear all your positive stories. Hop on the Tell Your Menopause Story Facebook page, and there'll be more about that coming through as October approaches on my WellFemme Facebook page as well. So thank you very much again, Marita, for sharing all your expertise and wisdom about all things pelvic floor related. We love you, and it's been really enlightening. So thanks so much. Everybody, you'll be able to see the blog write-up from today, including the link for this webinar video, and you'll be able to watch that again. Or if you've missed out on it, you're probably watching this on a replay anyway, so you already knew about it. Okay, have a great evening, everybody, and look out for next month's webinar topic. Okay, bye.
Bye. Thanks.